I will be speaking for next 12 minutes to give you a basic presentation on what lipids are and how they pose the risk. So what are lipids? Lipids are basically a broad group of naturally occurring molecules that include fatty acid, waxes, eicosanoids, monoglyceride, triglycerides, diglycerides, phospholipids, sterols. But out of these lipids that include fat-soluble vitamins also, approximately half of the circulating lipids are sterols like cholesterol and cholesterol esters, and the other major components include phospholipids and triglycerides. So that is number one. The first thing regarding lipids, the blood lipid abnormalities, they rarely manifest into any symptoms. So in exceptional circumstances and in certain situations like genetic dyslipidemias, you would have certain manifestations which indicate that the patient may be having dyslipidemia like tendon xanthomas, xanthelasmas, eruptive xanthomas, and Palmer xanthomas. Lipids are not manifesting clinically except for their complications in the form of atherosclerosis. And therefore, the diagnosis of dyslipidemia rests on laboratory examination. Basically, lipids have got certain functions about which I am not going to talk about. I am going to talk more about the lipid transport system. And this lipid transport system is something that has evolved over millions of years to carry the hydrophobic molecules, that is fat, from the sites of origin, that is intestine or liver, to the sites of utilization, that is muscles or adipose tissue, through the aqueous environment of plasma. So the hydrophobic elements of the lipids like cholesterol esters and even free cholesterol, they cannot mix with the plasma because of their hydrophobic nature, which is basically an aqueous. Therefore, they circulate in the form of lipoproteins. And these lipoproteins, irrespective of which lipoprotein we are talking about, except for free triglycerides, they circulate in the form of these lipoproteins, which have a coating of phospholipids and apoproteins, and along with that, and the core is the cholesterol ester and triglycerides, both of which are hydrophobic in nature. Now, the surface may also have other elements like antioxidants, beta carotene, vitamin E, unesterified cholesterol, but mostly the hydrophobic elements of the lipoproteins are at the core, and the aqueous elements like phospholipids, etc., they are at the outer coating. And in this apoprotein of different forms, they form the core along with from the surface along with the phospholipids. So depending on the size and the density of lipoproteins, we could classify lipoproteins circulating in the blood as chylomicrons, chylomicron remnants, which are depleted of triglyceride at least partially, intermediate density lipoprotein, which is also a remnant particle, LDL, HDL, and as you can see, as the density keeps on increasing, there is a decrease in the size of these particles. Now, you could subclassify these particles into small, dense LDL, large LDL, small HDL, larger HDL. So these classifications, of course, are artificial, but nevertheless, it is important to remember that they have got certain place in the scheme of things as far as the lipoprotein metabolism is concerned. So without going into the details about what is the density of VLDL, IDL, LDL, or HDL, what I'm saying is that as the size of the lipoprotein particles decreases, there is an increase in the density, and the ultimate is, of course, is lipoprotein A, which originates from liver, and it has got the highest density. Now, the other point that I would like to mention here is that the nature of apoproteins covering the course of the lipoprotein also depends on the type of lipoprotein. Say, for example, for chylomicrons, the major apo is B48, which does not get attached to the LDL receptor, whereas VLDL, IDL, and LDL all of these, they have B, ApoB100, which is instrumental in getting attached to the LDL particles, and that is how the internalization of the LDL particles, ideal particles, and other atherogenic lipoproteins is taking place in vivo. Now, regarding HDL, well, HDL internalization is through a different scheme altogether, and we will not talk much about it because of the paucity of time. So, very briefly, lipoprotein metabolism, and there are lots of enzymes and steps are involved. But what I would like to say is that there are two basic pathways: triglycerides coming on from intestines, cholesterol coming on from intestine, that is exogenous pathway, and the internal pathway that is originating from the liver and some other cells of the body. So, as far as the intestinal pathway for triglycerides is concerned, this is something that leads to formation of chylomicrons, and at the level of the adipose tissue, the endothelial LPL leads to an action which depletes these chylomicrons of the triglycerides, and what remains is the chylomicron remnant, about which the only point that I would like to say here is that it is also supposed to be somewhat atherogenic, though it is not a classical pro-atherogenic particle. The other thing that is originating from the intestine is the nascent HDL, which acquires cholesterol, which gets esterified by LCAT and gets into an immature HDL, and with further maturation, it gives rise to a mature HDL, which is basically anti-atherogenic, supposed to be, because it is involved in reverse cholesterol transport, but more of that later. As far as liver is concerned, that plays a very central role in lipoprotein metabolism. Liver leads to endogenous synthesis of the cholesterol as well as triglyceride from the free fatty acids, which come and enter the liver cells from the muscles and adipose tissues. And this leads to formation of VLDL, which gets converted into IDL with removal of the free fatty acids. And with further transformation, it gets into the formation of low density lipoprotein cholesterol. And there is a continuous way of circulation and recirculation where the LDL ultimately is taken up by the liver again. So the point that one needs to remember is that it is not only LDL which is atherogenic, but also IDL, VLDL, and other remnant particles. Therefore, when we are talking of the total risk, we should take into consideration the total number of particles containing V100 rather than LDL alone. So, as Dr. Manoria said, that hepatic low-density lipoprotein receptor on the liver cell surface plays a central role in cholesterol homeostasis, and it is the underexpression of LDL receptor which leads to several forms of genetic dyslipidemia, particularly familial hypercholesterolemia, which may be heterozygous or homozygous. But the LDL particle that keeps on circulating and recirculating with affecting the influx of the LDL particles inside the cells, which gets recycled with lysosomal degradation, releasing the cholesterol, and this LDL receptors, they once again reach the liver cell surface to take up more LDL. But there is another mechanism, PCSK9, about which you will be hearing a lot in the future talks today. But this is a counter-regulatory mechanism where it is a protein which is secreted by the liver into the plasma, and it binds LDL receptor on the surface of the hepatocyte and targets LDL receptor for degradation. So depending on the gain of mutation or loss of mutation or manipulation by pharmacological methods, PCSK9 inhibition can give rise to a decrease in the LDL cholesterol levels circulating in the blood. Now, as I said, the remnant particles, they are also important. One should not forget their importance. Now, coming on to, and I will not be talking much about LDL because in the next few hours, we will be talking more and more about LDL reduction. But let me say a few words regarding the hypertriglyceridemia. Now, what about triglycerides? Now, triglycerides theoretically have got a lot of effects which may increase the risk for atherosclerosis, like hypertriglyceridemia is associated with metabolic consequences like increase in chylomicron remnants, as I told you, increase in the VLDL remnants, the endogenous pathway, increase in intermediate density lipoprotein, and also there is a reciprocal relationship between triglycerides and HDL, which means patients with high triglyceride levels, they tend to have low HDL because of the action of an enzyme called CETP, more of later. But also, in addition to that, hypertriglyceridemia is associated not only with decreased HDL, but also preponderance of small LDL, giving rise to what is known as the Ldl pattern B. The hypertriglyceridemia also leads to an increase in the risk for blood coagulation and decreased tendency for fibrillosis.
1 minute left.
Yeah. So as I said, the CETP mediated transfer of cholesterol, ester, and triglyceride mutually between high triglyceride levels circulating in the blood and the HDL leads to formation of two things, basically small dense LDL and small dense HDL. And small dense HDL gets rapidly excreted from the kidneys, leading to a decrease in the HDL levels circulating in the blood and preponderance of small dense LDL, giving rise to high triglyceride, small LDL, and low HDL cholesterol levels. And this is what is known as classical Ldl pattern B, which seems to be more atherogenic as compared to the classical pattern A. Now, this pattern of small dense LDL with low HDL and high triglyceride, that does not start appearing beyond the classical recommendation that the triglyceride should be more than 150. It actually starts appearing as a triglyceride level as low as 95 milligram or 100 milligram per deciliter. Now, despite the fact that we have observational studies, meta-analysis of population-based studies, whether hypertriglyceridemia per se is an atherogenic factor or not independently is really not known. And it is quite possible that high triglyceride risk, as far as atherosclerosis is concerned, could be because of not triglyceride, but because of the other markers which have an independent effect like small dense LDL and low HDL cholesterol. So these are all observational studies, and the cause and effect really are not known. So the major therapeutic target for triglyceride reduction is reduction in the risk for pancreatitis, and anything that is achieved by way of decrease in the risk for atherosclerotic events is probably incidental. We really don't know at this moment. Now, regarding HDL, once again, the independent effect of HDL, we have, Framingham study and, so many other epidemiological studies, but we really don't know whether HDL really is an independent risk factor for occurrence of atherosclerosis or decrease in the risk for atherosclerosis. And it's a very complex thing, Theoretically speaking, HDL has got many beneficial effects like inhibiting the expression of endothelial cell adhesion molecules, which is an initiating step in the occurrence of atherosclerosis, decrease in the oxidation of LDL, and promoting the efflux of cholesterol from foam cell, what is known as the reverse cholesterol transport. But also there are many other benefits of HDL which could be contributing if it is really an independent factor, like promoting the nitrous oxide production by the eNOS by a variety of other mechanisms. Then, of course, it also promotes endothelial monolayer integrity. Antithrombotic actions of HDL are also known. HDL is supposed to be an anti-inflammatory agent, but the word of caution here that HDL levels may not be that important as their functionality. Can just give me a second? There is something. Yeah. So there is some evidence that patients who develop atherosclerosis despite high LDL or optimal HDL could be having dysfunctional HDL. And this occurrence of dysfunctional HDL in atherosclerosis is also supported by the observation that certain inflammatory conditions like acute infections, particularly viral infection like influenza, may lead to dysfunctionality
Dr.
of
Jain?
HDL. Yes, please.
Sorry for interruption. Can you kindly conclude your session because we are already
Yeah,
late?
it's about to be over. There is some problem with the connectivity. That's why I'm taking, a lot of time. So we really don't know, and HDL is not basically a target for treatment at the moment. We really don't have anything worthwhile to say that this is going to increase HDL, leading to a decrease in the occurrence of atherosclerosis. Now, non-HDL, that is the last part of it. This is something, total cholesterol minus HDL, and this probably is one of the strongest, and most predictive of the future risk of the atherosclerotic events and the occurrence of atherosclerosis, because it is something that reflects the total atherogenic cholesterol circulating in the blood. Now, compared to this ApoB, which is also reflecting the same and has a good predictive accuracy and better than LDL, the predictive accuracy of non-HDL is almost as good as the non-HDL, and therefore in clinical practice nowadays it is promoted that if you measure non-HDL cholesterol, it will be as good as estimating the ApoB. Thank you very much.